My name is Charles Webster. I am Wareflow on Twitter, W-A-R-E-F-L-O. All of my slides are tweets. People sometimes say I feel like they think I'm tweeting PowerPoint slides, and so that's what I use them for. If you are on Twitter, please use EHR Workflow NOV5. Alrighty, overview. I'm going to talk a little bit about Ebola, EHR, and workflow as in a kind of a torn from the headline sort of way. And then I'm going to talk about the basics. What is workflow? What is workflow technology? And then a little bit more at length about engines, editors, and visibility. By the way, that's my main blog there, chuckwebster.com. And thank you for everybody who retweeted this outline over the last couple of weeks. Okay, sometimes people call me the workflow bear, and they talk about poking the workflow bear. So they're in some conference, and some guy or gal starts talking about workflow and EHRs and health IT. So they'll take a picture of the slide, they'll quote them, and they'll include my URL or my handle. And and I always respond. So it's kind of like I'm a sleeping bear, and you poke me, and I wake up and I say something. So on October 3rd, I woke up and I had hundreds of mentions and people emailing me, including health IT journalists contacting me through contact forms on one of my blogs, asking me about this headline, which is Dallas Hospital Blames Flaw in Workflow for Release of Ebola Patients. And so actually I ended up quoted in quite a few health IT publications. It was kind of an exciting moment for me to see workflow kind of up there in lights. Now, interestingly enough, the next day, the hospital retracted this statement that there was a flaw in the EHR workflow, and the other half of the health IT community went, aha, it was a human or user error. And we'll talk about that at the end of this presentation. But on the second, when the PR release came out, which I read on the 3rd, it talked about visibility of workflow. So the nurse collected the information, supposedly, about travel from Africa, and this somehow, the result of this wasn't part of the physician workflow, it wasn't visible. And so all of this is going to be kind of a build-up to what does it mean technologically, but I'm going to use a lot of analogy and metaphor to make workflow tasks more visible. Okay, let's start with the basics. I have looked at literally hundreds of definitions of workflow, some of which would fill multiple PowerPoint slides. This is my favorite definition because I made it up. A series of steps, consuming resources, achieving a goal. So if you've ever written out a workflow on a napkin, labeled boxes with little arrows to explain workflow to someone else, I'm sure you're familiar with that. Consuming resources. Each workflow step requires a widget from inventory or the time of some user or some access to some other system it's talking to. And it consumes these resources. It can't proceed without those resources, but it also costs something. So the amount of time the user spends interacting with, let's say, a data entry screen is part of that. And then finally, the workflow achieves a goal. That goal is the benefit of the workflow. So what we've connected up here is the series of steps to cost and benefit. If the cost and the benefit change, if the economics of the workflow change, you should be able to change the workflow. Unfortunately, many workflows in health IT and many EHRs are relatively frozen, and that's one of the sterling qualities that workflow technology brings to EHRs and health IT, is it makes it easy to change the workflow when contexts change in order to make the users happier and more effective, efficient. Okay. A competent OR nurse, hands the right instrument, forceps, scalpel, in the right orientation to the right person at the right time. An EHR workflow system hands the right screen, which could have data or order entry options, to the right person at the right time. Now, how does it do that? EHR workflow systems have what's called a workflow engine. So this is a Corvette engine, and it's executing a workflow. Now, if you think about the bad old days, with some of which are still around, 15, 20 years ago, you had to navigate through an incredible thicket of menu hierarchy in order to move from screen to screen. Now, you have to do a lot of clicking to move from tab to tab. And a lot of physicians complain about not wanting to be data entry clerks. I don't think the issue is so much data entry or order entry, it's all the navigation to find what you need. So I read the other day, this guy said he had to look at 10 different places in the system to find the information to write a note. So here we have a very basic workflow. Let's say the patient's being taken to the exam room, the nurse asks about allergies, medications, takes some vitals information, an initial chief complaint, reason for visit, and then another person or role takes over. The physician conducts a physical exam, makes an assessment, prescribes something, okays some codes to go off to the billing system. That's a very, very basic ambulatory workflow. And instead of the user having to drive the screens from screen to screen and find the right screen or find the right person or figure out that they are the right person, the workflow engine is putting up the right screen at the right moment for the right person. And that is part of the magic or the intelligence of the workflow. Now, how does the workflow engine know which screen to present to which person? Well, the workflow engine consumes a definition of workflow. This down here, definition is a short description of a thing by its properties. That's actually a 400-year-old definition from the first dictionary. And so over here on the right, we have the human editor. The human editor can change the order of those steps, change a little bit of the business logic. This is no longer optional. This is now mandatory. Within 5 minutes or 10 minutes, if it's not done, I want it to escalate. All of that can be specified by someone who is not a Java programmer, not a C# programmer, not a mumps programmer. Now, we're not here yet, but this is where we're headed. Okay, imagine most tasks are associated with screens. Now, there are screenless tasks. Those are the little dotted lines. But some of these screens are going to have data, such as the last physical exam or the most recent lab values. Some of these screens are going to be order entry screens, such as entering an assessment or a prescription. Imagine you could drag and drop them into your workflow model that's going to be executed by the workflow engine. And then do you double click on them, say, no, this one I don't want to be optional, I want it to be mandatory. And if it's not done, the patient literally cannot be checked out of the office if it is not accomplished, and it will escalate to a supervisor. But this is a more typical workflow editor. It looks a little bit like Viz.io if you've ever drawn flowcharts. We've got these yellow decision points. We've got icons representing nurses and physicians, and this is part of a workflow in an emergency department. And there's something that the programmers and the workflow analysts call the happy path. The happy path is from the left to the right, from step 1 to step 9, and it's what you expect to happen, you normally happen, and you try to facilitate and save people a lot of work and a lot of clicking. And then you have these exceptions down here, so they're dropping down, so it doesn't meet the clinical requirements for that step in the workflow, or the person doesn't have the insurance, and that tweaks the workflow. These can get pretty complicated. I like the pick list model of workflow. It's easier for folks that aren't analysts to see what's going on and to change it, such as delete a step or change the order or change who's responsible for a step. Okay, now we're going to talk about visibility. But before we talk about the relationship between customizable workflow engines, and task visibility, we need to lay a little bit of groundwork. Now, 15 years ago at HIMSS in Atlanta, so HIMSS 00, this was one of my presentations, and it was called Workflow-Enabled CPRs. This was even before people called systems electronic health records or electronic medical records. These were computerized patient records. In the middle, you have that engine that I'm talking about, the engine that consumes instructions. Over on the right, you have the aviation cockpit. I spent a year in aviation human factors at the University of Illinois during my graduate degree in industrial engineering, one of the top programs in the world. And I learned about Pitt's Law and Hicks' Law. Pitt's Law is the larger a target is, the larger a button it is, the easier it is to hit accurately and quickly. Hicks' Law is the number of options on the screen. The fewer there are, the more likely you can select the right one. It's the job of the workflow engine, consulting the workflow model, to put the right buttons on the right screens, and to filter out all of that extraneous, irrelevant content. If you don't have that workflow engine, you get an explosion of the space you have to search in order to figure out what to do next. But even if you have a workflow engine and you have a user customizable and improvable workflow model that's being executed, sometimes tasks still fall between the cracks. And so over on the left is the control tower of an airport. In that tower, you have what the usability engineer calls a radar view. You can see all of the patients and all of the planes, how long they've been waiting in their exam rooms, on their runways, or stacked up. You know how many minutes of fuel they have left, and you can note exceptional circumstances and jump in there and fix them so to maximize throughput while preserving safety. That's actually called BAM, or Business Activity Monitoring, in the business process management world, which I will talk about briefly at the end. Okay. The two major conceptual valuable things that workflow technology brings to electronic health records are smart sequences and simultaneous actions. So sequences could be a task that's passed from role to role or from person to person. And here on the left, we have the patient going from the waiting room into the exam room, the nurse doing some stuff. I've kind of suppressed that detail because I want to focus on the set of tasks that the physician does. Now, a lot of what the physician does is document and then do some orders, and eventually someone will, act on those. But in this case, not only is the physician documenting, but also directing and delegating in the midst, inside the exam room, and the next step. So, for example, this person is late for vaccination. The engine says, okay, well, if that's true, then the next step is to set up the immunization tray. And all of this, the immunization trays, tests, procedures, can be happening in parallel at the same time the patient is in the room. This dramatically reduces the cycle time, which is the amount of time it takes to get into and out of a practice, and can result in a great increase in both patient volume and patient satisfaction, because they don't have to spend as much time in the system. Here's an example of an office view, in this case called a radar view, in this case called an office view. And like I said, most of these are tweets. So I'm having a conversation here with an internist in Montana and a pediatrician in Georgia, and we're talking about this office view. We see exam 1, room 1, 2, and then we see colors here. So we have a green doctor and a blue doctor. So Elizabeth Perkins the green doctor is their primary care physician. Then there's the blue over here, Sophia Packard. Now, what's interesting about this screen is, first of all, you have a little bit of information about them, but you see the number 8. That's the number of minutes that the person has been waiting. And then next to it, we have vital signs, and then going down the column, we have the exam, vaccine signature, and we see the number of minutes. If we were actually watching the system live, we would see every minute those would increase. Now, here's the thing. There are a lot of systems out there in which humans update this data so that everybody can see what's going on. This data is live, and it's there because the workflow engine has access to it. It's there as a byproduct of the execution of the workflow engine. So all of this task status information can be compressed together in a real-time report, and everybody can see moment to moment what's going on. And they know that each other knows what's going on. There's just a tremendous kind of mind meld that can happen there. And by the way, I talked about task status. Listen to this list. A task can be not in the workflow, can be in the workflow but not available because it's blocked by another task. It could be started, it could be available, but not yet started. It could be started, but not yet completed. And before it's completed, it might be postponed, it might be canceled. Someone might have to give a reason why. If it languishes too long, it might escalate, okay? And finally, it could be completed. So all of this task information is automatically available, and you can choose the best information in real time. And also, it's incredibly valuable for workflow analytics afterwards to spot the bottlenecks and find the rework and so forth. Okay, what's it like to actually use an EHR workflow system? Well, in 2003, 4, and 5, the first 3 HIMSS Davies Awards for excellence in ambulatory EHR use went to an EHR workflow system. And I'm quoting from those 15-page applications. And in the lower right, you can see EHR.biz, HIMSS Davies 2003. You can actually pull up the original application, and I'm quoting from it. So, Dr. Cooper, pediatrician, is talking about He's not talking about an electronic health record. He's talking about a workflow management system. It allows him to customize and streamline collaboration among providers and staff in ways that improve efficiency. For example, while he's in the exam room with the patient, in addition to documenting, he's also directing and delegating. That's that starburst of arrows in the workflow model that are going from the left side with smart sequences out to simultaneous actions. He says, we pass each other, me on the way out, they on the way in. I go immediately to the next patient. Well, they immediately perform their procedures. I don't have to find them. I don't have to tell them what to do. I visited a practice using an EHR workflow system, and it was really strange. It was like one of those Stooges hallways where the three Stooges, and they're running out of the doors and they're crossing into the other door, and they're not without saying anything to each other. And what I couldn't figure out is how do they know where to go next? Well, as he says right here, it's the EHR workflow management system that's taking care of that task-driven communication, which is what workflow systems and EHR workflow systems excel at. Let's look at another one. This is in 2005, Dr. Harris, Family Medicine, Obstetrics and Gynecology, and he talks about we've got one screen at a time with only the most relevant data displayed and options presented. That's the aviation cockpit where we're using the workflow engine, the knowledge of the workflows of the pilot and the co-pilot and the navigator to strip out all of that extraneous stuff and only present the relevant information. He goes on to say, well, a user can always jump out of a particular screen sequence to accomplish a task. So you're not a slave. It's really just being helpful. And if you keep jumping out of that workflow, maybe you need to go back to that workflow model and tweak it. So he says sequences can be tweaked through the workflow management. That is going through the workflow editor and changing the description of workflow, the model of workflow that is driving the workflow behavior of the system. The workflow plans can be tailored for each type of patient. So, for example, a well child visit that is an annual physical versus a child coming in for management of a chronic asthmatic condition. A different set of screens queued up to different folks, different business logic, and all of that can be customized by the practice without having to go through a Java or a C# or a MUMPS programmer who really doesn't understand their workflow. And then down here we have the work plans, which are the workflow definitions, contain the required tests for specific conditions, so they're not forgotten. They're not forgotten because when they are queued up, they don't go away. You see them in the office view, and they hang around. The patient can't leave until they are either accomplished or dismissed for good reason. Okay, now we've come to the conceptual core of what I'm talking about. And I like to talk about the power of process, the power of executable process models. So in the middle here, we have models of work, models of workflow that are executable, that are mechanically consultable in order to help the users. And in the middle, we have this Vis.io model version, and here we have the pick list kind of version, which is, patient go to the exam room, ask about meds, ask about allergies, collect some vital information, and then it moves on to the physician and on to billing. Well, you may have seen this little colorful gadget right here. This is a workflow. The red corresponds to clinical assistance, and we're, vitals, meds, allergies. And down here, blue corresponds to the physician, exam, assessment, and treatment. Green here makes sense is the billing, and the happy path are these black arrows, and the exceptions are the red arrows. And now this model is probably only a third or a fourth as many of actual workflow task states in a sophisticated ambulatory. But I think it illustrates. But this model is something that's in between the computer and the workflow engine, but it can be understood and executed. And over here, we have someone who isn't a programmer who can understand that workflow and change it. And this is the layer that's missing in most traditional electronic health record documentation systems today. They are documentation systems. They are not workflow systems. Here's a hospital context, and this is a slide I tweeted. We have Ottawa Hospital. They're working with IBM, and up here we have a patient And then they go home, but in between we have all of the workflows and the tasks and the information that's flowing, labs, nursing unit. Down here we have all those terrible databases full of images and structured data. And this layer right here is missing in most health IT environments. So the users have to navigate and figure out what table and what row and what column to find the information, and maybe 10 times like the guy I mentioned earlier just to write a note. Instead, we need to have a model of work that is executable and is improvable. So right here we have the beginning of the workflow. Over here we have the end. We have diamonds corresponding to various kinds of logic. Here's a timer. That timer could represent wake up at 3 a.m. in the morning, download some information, look at the meta information, put a tickler in the right to-do list. We have data right here that's being transmitted to and from the system. I talk about the importance of workflow interoperability. We need this layer of workflow, this model of work, to really make the syntactic and semantic interoperability that most people focus on valuable. Okay, we're going to zoom back out here. I've been using the term workflow and workflow technology because I think workflow is a popular term, I think, in healthcare. But the workflow management industry is really now called the business process management industry. And healthcare doesn't really always like the word business. So you'll often see clinical process management or healthcare process management or care process management. But if you drill down and you look at the footnotes, you'll see what they're doing is they're leveraging business process management suites, workflow engines, orchestration engines. In fact, a number of the more sophisticated population management systems and care coordination systems that are coming out onto the stage right now in health IT are in fact based on business process management suites of various brands. Okay, back to Ebola, EHR, and workflow. Now, let's say we've got the workflow model there and the travel information is optional. So we go in there and we click that. We say, no, we're going to require it. It's going to become required. And by the way, if it's not accomplished, we can't check the patient out. Workflow models are declarative. They could be transmitted. You can export them as XML and you can send them. So you can imagine workflow models being transmitted from public health departments down to point of care EHRs in ambulatory and hospital environments. The nurse collects this information, and somehow it didn't get to the physician, at least in the first version of this. Well, EHR workflow systems excel at task-based communication. They do very, very well exactly what traditional EHR documentation systems do badly. And so the nurse, it would have been on the fourth, remember that group of folks who said, you know, just because you have an EHR doesn't absolve the clinical care team of the common sense responsibility of communicating. The nurse should have taken the physician aside and said, look, this guy just got back from Africa. Well, guess what? In a workflow system, it would be very easy for the nurse to simply click recheck and assign the duplicate task to the physician role. And that physician would not have been able to leave the emergency department until the physician saw it and signed off on it. Okay. Of those 3 HIMSS winners, this is my favorite. Dr. Gonzalez is in Chicago. He's spoken at HIMSS. And he's got this quote. You can actually go to the URL here, ehr.biz, HIMSS Davies, 2004. And he says, it's really helped my lifestyle. I'm working 3.5 days a week. I used to work 7 days a week. So now it's really made life much easier and the staff love it. So it's really made life much easier and the staff love it. How often do you see that being said about traditional EHR documentation systems? And look, he used to work 3.5 days. He used to work 7 days, now just 3.5. He has doubled his productivity. This system has made him able to accomplish twice as much with the same amount of work, or as much work with half as much effort. Whereas traditional EHR documentation systems do the opposite. They often double the amount of work and make people stay late. Okay. I am so delighted to be here in this digital bully pulpit. Workflow technology, BPM, adaptive case management is diffusing into healthcare across a multiple fronts, social, mobile, analytics, clouds, and I'm happy to try to help accelerate that. I'm Wareflow on Twitter, W-A-R-E-F-L-O. I have about 1 million words about healthcare and healthcare technology out there. Just search for Chuck Webster Workflow, you'll find it. There are contact forms. I hope you will join with me and become a workflowista. Viva la workflow. Thank you very much.
So I'm going to encourage anyone to stick more questions into the chat box, but we'll jump in here for the first question for Dr. Chuck Webster. What obstacles are there to getting better workflow technology adoption, and what needs to happen to increase adoption?
That is a very, very good question. And my answer is three things. I'll try to keep this short. And that is, first of all, education. There are a lot of precocious physicians who are becoming CIOs, and they're learning just in time, and they're learning about workflow technology from other industries, which are literally decades ahead of healthcare. Number two is we need to find the health IT people and the EHRs that are already doing workflow well. They may have developed their own proprietary EHR workflow engines and so forth, and to highlight them. And I didn't show it here, but I have something I call the POWHIT badge. It's a social badge. POWHIT stands for People and Organizations Improving Workflow with Health HIT, and POWHIT, like, you know, the Batman TV show. And number three, I think we need to harness the workflow technology industry itself, the BPM industry, which is 1/10 the size of health IT globally, but is growing 3 times as fast. And so I know of folks that are swapping out their proprietary homegrown workflow engine for, workflow engines from third-party vendors. And so that's my answer in terms of changing an industry. I think those three are those are the tines of the fork, or whatever, to mix a metaphor.
So, question for Dr. Rogu: how, in your example, would the combination of fever and travel from West Africa in the last 21 days trigger an alert or a branch that ensured closer physician scrutiny? Or are there other ways within the system that could be highlighted to someone else in the practice through the workflow?
Well, that would have to be configured a little bit. It's not very complicated. Today you would want to make it a mandatory step. So you would just create a service bar with visit reason for fever. What we did was, in our review of systems where there's a fever, we just added, in that context, what is the travel history? It's not mandatory, but if it needed to be mandatory, we could make it mandatory, where we just, just make another service bar. Like, if you recall, where I had that first service bar where it was meaningful use to check the vital signs, you can make one of those things travel history. The doctor cannot go forward without asking or the nurse.
And I guess someone who was thinking about it could probably send an alert to another practitioner in the office?
Yes. You can. There is a feature in Excite Health where you could send alerts that pop up when anybody touches the chart. We do that a lot with, like, people that they don't like vaccinations or they're behind on vaccines. So today's doctor will say, at the next visit, give the MMR and the varicella. So when the doctor goes in and touches that chart view, which is the big picture view, it automatically pops up and it tells them you should do this.
So for Chuck, how do we engage care delivery enterprise organization CIOs to adopt workflow technologies? That's a big question.
And it's an excellent question. Last year, I actually co-facilitated a focus group at Chime in Arizona. We had 40 CIOs of the top medical centers in the United States, and we talked about workflow, business process management. And the interesting thing is, and this is part of another trend, I've noticed job ads looking for hiring CIOs and even CEOs of hospitals in which they say lack of healthcare experience is a plus. And so basically the CIOs in these hospitals who came from other industries that have been using business process management for almost 20 years are ideal candidates for helping that technology diffuse. On the other hand, their plates are so full of ICD-10 and meaningful use that it's a battle. And so we have to make our case as enthusiastically and as credibly as possible in the ways that I referred to earlier. Find and highlight, harness, and educate.
Okay, great. Thank you very much. So I'm not really sure who wants to answer this one, but I'll read it out. Why do you think existing EHR systems, both ambulatory and hospital, have not yet, if ever, implemented workflow engines?
I'll answer that.
Okay.
Well, health IT about 20 years ago, maybe 15 years ago, came to kind of a fork in the road. There were early workflow systems implemented in HIT. Health IT, and I don't mean to offend anybody, has a bit of a data fetish. Okay, it's all about the data. Well, guess what? It's also about the workflow. And to when you set up very ambitious goals involving data collection, and it sucks all the air out of the room, and you can't address the workflow issues, then you have a misbalance. And so what I'd like to see is if we could, take instead of 90% data and 10% workflow, if we could do 70% data and 30% workflow in terms of emphasis and hype and education and money from the government. An investment from venture capitalists, I think we can maybe start to shift the balance back in a more equitable direction.
Okay, great. Thank you. Dr. Rogu, do you ever need to take charts home after hours to complete records because there is no time during the visit?
That has never happened. We complete the visit during the visit. So I go through each step, and I turn around and I speak to the patient, and since I'm using my fingers, very little mouth clicking, it's very efficient. I have not one time taken any charts home. But that is a common complaint that a lot of doctors have with other EHRs.
And I guess I kind of just heard you also say, and I've experienced this as a patient, is you actually get to look at me in the face with this perhaps system, where sometimes I find the physicians are buried in their computer and not even looking at me anymore.
Well, I have a hardwired, they're called WISE devices. It's plugged into, it's on the wall of every exam room, and we have a keyboard and a mouse. That's all that's visible. So I touch the screen, I'll go through something, I'll turn around, I'll touch the screen, I'll write some more, I'll turn around. You have to do that turning around. You cannot sit face to face with the patient, but this is the next best thing.
Okay, and then perhaps a related question, do you see less patients than with paper charts?
What has happened is our office is quiet all of a sudden. I think we see more, if not the same volume. We definitely do a better job of documenting, and I think by doing that you do a better medical job. We do better recallers and follow-ups. And I think we do just as much as we did before, but there's no more stress, and everybody leaves on time. Everybody's happy, and the patients are happy. We have a law in the office. If it's a sick visit, from check-in to check-out, from check-in to the time the doctor leaves the room and is finished, has to be within 30 minutes for a sick visit. And for a well-care visit, it has to be within the hour. That's pretty darn good, I think.
Okay, great. Thank you. So again, this one is, I'm not sure who wants to answer it, but do you see wearables and workflow EHRs working together?
I'll take that. And I'm actually giving the keynote at the Society for Health Systems Healthcare Systems Process Improvement Conference in February, and I am talking about wearable workflow. And the relationship between Google Glass and notifications sent to smartwatches and to other gadgetry and how they fit into the larger enterprise health IT system. And so I don't want to give that presentation to you now in response to a question, but yes, there's a tremendous opportunity. I'll just give one example. One of the Google Glass companies is estimating they can reduce maybe 30% of the interaction between the physician and the EHR can be offloaded to intelligent alerts that come to the physician, and the physician doesn't have to go off and search through the EHR to find the data.
Okay, great, thank you. So for Dr. Chuck Webster, how do we include the patient in the workflow?
What a wonderful question. I actually have a couple of blog posts about the relevance of workflow technology to patient experience and engagement. And in fact, it is in the consumer-facing, patient-facing cloud-based social startups and platforms out there that I am seeing the most sophisticated workflow technology. So folks are developing these using what are called less code or low code techniques, where they're drawing the application, they're drawing the workflow, and these systems are very natural for, let's just include the patient as another member of the team. So you actually model it. You actually, when you create your workflow model, that workflow model, those resources are not just doctors and techs and nurses and admin, they're also the patient. So we're making the patient a first-class citizen in the process-aware information system. So I think that we're just scratching the surface. And as I said, some of the more sophisticated workflow technology is actually coming into health IT from these consumer-facing, patient-facing systems.
Okay, great. Thank you. Another question, just open to anyone. What is anyone's opinion of YAWL? Yet another workflow language, so YAWL.
Yeah,
I've just started reviewing it.
I'm familiar with YAWL. YAWL is an open source business process management application that you can download for free, developed by some Dutch researchers. They may actually be listening in. It's an excellent educational tool. I don't know that it's actually been pressed into actual everyday use. I know that people have tried it out and prototyped it in hospitals, but it's basically a free open source. And in fact, if you ping me or email me, there's about a dozen open source business process management systems out there, and they're getting better every day. And I'm hearing more activity where people are saying, let's try this out in healthcare.
So for Dr. Rogu, how is this different from other systems you have used?
It is different because I've reviewed lots of systems, and they are all basically just glorified progress notes. This is more than just a progress note. It just makes the office run efficiently. Like I said, from orders to billing to movement of patients within the office, and then also the progress notes. I mean, I think EHRs, the progress notes was used from 5 years ago. I think this is the future.
So here's a general one. Actually, I've got two more questions, so if anyone has any more questions to put in, please put them in now so I can finish them up. That would be great. So for anyone, I thought workflow was about interoperability, but I didn't hear it discussed.
I'll take that. There are three kinds of interoperability, and the terms all come from linguistics. There's syntactic interoperability, which basically means can you get the data from one system to another. There's semantic interoperability, which is does the data mean the same thing? So you've got some number or code, does it point or refer to the same drug or diagnosis? But out in computer science and theory land, there's a third kind it's called pragmatic or workflow interoperability. And it's basically when you send a message from one system to another, does it have the effect that you want? Does it achieve the goal you want to achieve? And the current systems that are focusing on interoperability at the syntactic and semantic level, when there's a problem and they send over some information and it's kind of garbled, you can use the workflow interoperability level to say, hey, I just got a garbled message. Is it what you really intended to send me? Could you send it to me again? I'm going to escalate it on my side. Could you escalate it on your side? And so that kind of conversation between systems is really missing from systems that are workflow oblivious. And we need to add workflow. So really, even though I was talking about workflow, I did mention, a task to wake up at 3 a.m. in the morning, download some information, and, read the metadata, and then put a tickler in the right to-do list. That's interoperability too.
So these models of workflow that drive electronic health record, EHR workflow behavior, where do they come from? Do I have to create them?
When the system comes out of the box, we have a lot of content that's already built into it with almost close to 17, 18 years of experience and working in so many different practice with hundreds and hundreds of doctors. So we created, for lack of a better word, some kind of a standard read content already. So that's ready to go, but the doctors, any doctor, like Dr. Rogu said, they can configure and change anything along the way, and each doctor can go with his own treatment plan, and that suits him and suits the way that he wants to practice medicine. He doesn't have to follow a certain progress, a node way or that is already built into the system. He doesn't have to look for the right fields to fill them in. Here, like Dr. Rogu has demonstrated, once he configured any changes that he wanted to do, when he pressed the set up, he gets a screen that this is a result of the action that he made. And like I said, it's pretty much ready to go, but it can suit anybody's configuration.
Okay, great, thanks. Dr. Chuck Webster, your comment.
I grew up on the banks of the Mississippi River on a farm that was homesteaded in the 1800s, and every spring we watch the river. It's frozen, and then it finally starts to break loose, and then you see the volume coming down. I see healthcare IT as a little bit like that frozen river. I often talk about frozen workflows, but I also see a spring, and I think things are about to break up. Every year I look at every HIMSS exhibitor website and I search for workflow. 2 years ago, 8% had it in their technical documentation or marketing. 16% last year. I'm thinking it's going to be 33%. And here I'm talking about customizable workflow analytics, workflow editors, coming thing. And finally, social media is incredibly important to the educational part here. And I'd like to thank everybody who has showed up from Twitter, for example, and I have learned so much from you. And social media, I think, will be the way, both, and even Facebook and so forth. We need to get all the birds of a feather to band together and bang the workflow drum so that everybody else hears and joins the parade.
Super. Well, thank you all for participating today. Thanks to the audience for some fabulous questions, and we look forward to hearing your progress as you move forward. So everyone have a great day, and thanks for attending the webinar. Take care.
Thank you very much.
Bye-bye.
Thank you. Bye-bye.